Long case aortic regurgitation. Mr. B. Ahmed, 55 years old, day laborer, non diabetic, normotensive smoker, hailing from Jamalganj, Sunamganj, was admitted into this hospital on 10th August 2022 at 11 am through outpatient department with the complaints of increased shortness of breath for 1 month and increased palpitation for 1 month. According to the patient's statement, he was reasonably well 3 years back. Then he noticed shortness of breath during heavy exertion like working in paddy fields, carrying heavy goods, washing clothes, doing household works hurriedly, and it was relieved by taking rest for a while. This shortness of breath is progressively increasing in nature. Now his shortness of breath has got worse for last 1 month, which occurs during mild exertion such as doing daily activities like walking at home, bathing and dressing. Now it needs prolonged rest for improving his shortness of breath. He has repeated history of sudden awakening from sleep at midnight due to breathlessness for last 1 month and needs to go to the window for open air, and it improves after 10 to 15 minutes. He has no history of difficulty in breathing during lying flat. His shortness of breath is not associated with exposure to cold, dust, fumes, and allergens, taking drugs or food, fever, cough, coughing out of blood, bluish discoloration of tongue, fingers, or skin. It is not associated with swelling of leg, abdomen, or face, decreased urine output, and there is no diurnal or seasonal variation. He has also complained of palpitation for last 3 years, which he feels regular in nature. Initially it occurred with moderate to severe exertion and was relieved by taking rest for a few minutes. The frequency of this palpitation is progressively increasing in nature. For last 1 month it occurs even with mild exertion and takes prolonged time to be relieved. This palpitation is not associated with taking tea or coffee. Anxiety, depression, chest pain, dizziness, lightheadedness, transient loss of consciousness, increased frequency of micturition, vertigo or vomiting, weight loss or loose motion, and increased sweating, hand tremor, or heat intolerance. He gives no history of recent onset or prolonged unexplained fever, skin rash, neck pain, back pain, joint swelling, joint pain, weight loss, abdominal pain, parectal bleeding, vomiting out of blood, nasal bleeding, any focal weakness of his body, speech or swallowing difficulty, or any visual disturbance. He has no history of significant sore throat, fever with joint pain or joint swelling during his childhood, which is suggestive for rheumatic fever. He also has no history of known ischemic or hypertensive heart disease or any known congenital heart disease, traumatic chest injury, diabetes mellitus, asthma, COPD, childhood recurrent RTI, TB or contact with known TB patient, and documented COVID-19 infection. His bowel and bladder habit is normal. With these complaints, he had consulted with several physicians, and after evaluation, they have said that he has some sort of valvular heart disease, but he could not mention the name of his disease. He is taking some drugs for last 3 months irregularly, but could not mention the name of the drugs. He had never admitted in any hospital for his illness, and he had never undergone any invasive procedures or any history of blood transfusions. With these complaints, he has admitted into our hospital for better management. He was immunized as per the then government vaccination schedule and has got all doses of COVID-19 vaccination also. He is a smoker, smokes 20 packs a year, non-alcoholic, not betel nut chewer. He has no history of extramarital unprotected sexual exposure and no history of any genital ulcer. He is married, has 4 children. He has 2 brothers and 1 sister. His parents are not alive. They had died in their old age. All of his family members are in good health and none of them have any similar type of illness. There is no family history of sudden cardiac death. He has come from low socio-economic condition. He is a day laborer and one of the earning members of his family. On general examination, patient is looking ill, body build average, cooperative, decubitus on choice. Pulse is 90 beat per minute, regular in rhythm, large in volume, collapsing in nature, no radial or radiofemoral delay. Condition of the vessel wall is normal. All peripheral pulses are present and symmetrically palpable. There is presence of dancing carotid arteries or Corrigan sign is positive. Locomotor brachii or brachyilis is present over right arm. Quincke's sign is positive. Trope's sign or pistol shoot murmur is heard over the both femoral arteries. Durogy's sign is absent. Blood pressure is 140/40/0 mm mercury in both arms with no postural drop, and in both lower limbs it is 210/50/0 mm mercury. Here Hill sign is positive as systolic blood pressure difference between lower and upper limb is 70 mm mercury. JBP is not raised, respiratory rate is 18 breaths per minute and normal in character. Temperature is normal and periphery is warm. Patient is non-anemic, non-icteric, non-cyanosed, non-dehydrated. Leg edema and sacral edema is absent. There is no clubbing, leukocythemia or koilonychia. There is no thyromegaly or lymph adenopathy. Hair in skin condition is normal. There is an IV cannula in situ in left forearm. On precordial examination, apical impulse is visible and seems to be displaced laterally and downwards from the left midclavicular line. There is no chest wall deformity, size and shape of the chest is normal and there is no visible scar mark. There is no visible epigastric, supraesternal and supraclavicular pulsation. Apex beat is located in left 6th intercostal space lateral to the left midclavicular line, 11 cm from midline, diffuse in size, is felt over left 5th and 6th intercostal space, forceful, is sustained and hyperdynamic in nature. There is no thrill felt over the precordium. Left parasternal heave and palpable P2 is absent. First heart sound is normal. Aortic component of second heart sound is soft. P2 is normal. There is a high pitched, blowing, hollow diastolic or early diastolic murmur, decrescendo in nature, grade 3/6 in intensity, best heard at the left 3rd and 4th intercostal space along the left sternal edge, with the patient in sitting and leaning forward position with breath hold after expiration with diaphragm of the stethoscope. There is also presence of harsh ejection systolic murmur at the right 2nd intercostal space, grade 3/6 in intensity with no radiation, best heard with the patient in sitting and leaning forward position with breath hold after expiration with the diaphragm of the stethoscope. And there is also a soft, low-pitched rumbling mid-diastolic murmur present at the apex with no opening snap. Third heart sound is audible at the apex. There is no other added sound. Lung bases are clear. Regarding systemic examination, eye examination reveals lens and pupil is normal. Landolfi's sign is absent. Ophthalmoscopy is normal with absence of Becker's sign. Demasset sign and Muller sign is absent. Arch of the palate is normal. Respiratory system examination reveals normal. Abdomen examination reveals no organomegaly as well as no Rosenberg sign and Gerhardt sign. Musculoskeletal system examination reveals normal in stature with arm span to height ratio is 1:1. Wrist sign and thumb sign is absent. There is absence of joint hypermobility. There is no body structure abnormality like pectus excavatum or carinatum and kyphoscoliosis and no flat feet. This is all about the history and examination findings of my patient. So my provisional diagnosis is severe aortic regurgitation due to degenerative cause with sinus rhythm with NYHA class 3. Thank you.